our agenda for tonight. We'll discuss a couple of points, but basically they have been covered by my colleagues, so we'll cut to the chase, as they say. So we have an increasing incidence, mainly due to abuse of PPIs and better ability to pick up the neuroendocrine tumors. Basically, pathologically, from the oncological perspective, of course, we need just to differentiate between neuroendocrine tumors and neuroendocrine carcinomas. And of course, this is pathologically speaking. According to WHO, as mentioned with my colleagues, we have the 3 grades, and from the morphologically for the small cell and the large cells, and of course we have the mixed neuroendocrine tumors. There are some particular stuff about neuroendocrine neoplasia. It's wide anatomical distribution and a spectrum of behavior, also with the hormonal hypersecretion, which can occur in around 20% of the cases. 80 to 90% of the cases are well differentiated, and they do express the somatostatin receptors. Basically, whenever we see the patients, they are around 50 to 60 years of age. Primarily, it's in the GIT in 50% of the cases, 25% in the lung. And of course, we need to describe the tumor grade, the staging. Around 20%, as we said, are hormonally active, and around 20% are incidentally, what we call incidentalomas. And 5% are with multiple endocrine neoplasia, the hereditary syndrome. When we talk about the small nets, we need to keep in mind the local symptoms that may occur, also the hormonal syndrome. Whenever we have a carcinoid or excessive secretion of serotonin, all of us, we know the carcinoid syndrome. Basically, we see the bronchospasm, the carcinoid heart disease, which is extremely important, and of course, the classical flushing and secretory diarrhea. At some times, it happens that there is a carcinoid crisis, which may be life-threatening and needs high doses of selective serotonin antagonists. Pancreatic neuroendocrine tumors, again, patients complain due to symptoms which is local, maybe abdominal pain, jaundice, early satiety, or the hormonal syndromes, which occurs due to hypersecretion of insulin manifesting as hypoglycemia, or gastrin as in ZE syndrome. The Watha syndrome, of course, everybody went through the Watha syndrome when we were studying medicine, and of the glucagon due to the DM and migratory nephritic erythemia. The lung neuroendocrinal tumors, although it's around 25%, also has the local symptoms and the hormonal syndrome if they are metastatic for the atypical carcinoid syndrome. Cutting to the chase, how do we treat them? Of course, we have the selective serotonin antagonists and the longer acting ones with the octreotide, which was studied in the PROMET and the CLARINET. When they studied the octreotide, the long-acting form of octreotide and the lanreotide, of course, using these in the GI demonstrated significant progression-free survival in comparison to the placebo. Again, these are the trials of the using the selective serotonin antagonist when we used it in the SPNet or the SPINET trial, which was done on the lung. It had early termination, although it demonstrated progression-free survival benefit when using lanreotide, and they changed the primary endpoint to be PFS and demonstrated 16.6 months in comparison to 13 months. We have, of course, the cold, in contrast to the cold therapy, we have the hot therapy, the theranostics. Theranostics is integration of diagnostic and therapeutic, so using the selective serotonin receptor and binding it to diagnose or to better visualize these tumors using either the gallium dotatate PET when we want to do the diagnosis, or the therapeutic when we're using the lutetium. So basically, as we can see in the cartoon, we use the ligand, and we have the target. We have the ligand bind to a spacer, and then putting a radioactive nucleotide either in the diagnosis or therapeutic treatment of somatostatin analogs. And this is the NETTER trial using the lutetium dotatate, using them in the mid-guts neuroendocrine tumor, and of course demonstrating a significant progression-free and overall survival benefit, and also improved time to quality of life deterioration with lutetium dotatate will come. And actually this is very significant data, and it has been tested in comparison to other modalities of treatment. One of the singularities that we did when we tried to comparison different lines of therapy, also using the somatostatin targeting in the neuroendocrine tumors of the pancreas. Basically, there are two series, the Rotterdam series and the Bad-Burka series, demonstrating also significant overall response rate, progression-free survival, and overall survival. Targeting angiogenesis, of course, we have a rich vascular network with the neuroendocrine tumors, and we have an evidence from the familial syndromes like the von Hippel-Lindau, and several TKIs has been tested in the treatment of neuroendocrine tumors. One of them is the sunitinib. When it was compared to placebo, it demonstrated a significant progression-free survival with a significant hazard ratio of 0.42%, and demonstrating median overall survival benefit, again with a non-significant hazard ratio. There is the surofitinib, which was recently approved in China, basically again showing a significant median progression-free survival benefit when it was compared to placebo, but basically the diarrhea was again a significant health-related quality of life issue. The belzutifan, which is the oral hypoxia-inducible factor 2A inhibitor, which was tested in a couple of tumors, mainly related to von Hippel-Lindau disease and its associated pancreatic neuroendocrine tumors. It demonstrated a significant overall response rate of around 91%, 18% were complete responses, and a median duration of survival which was not reached, and it's being cooked now or being tested again in the rest, the non-von Hippel-Lindau related. Targeting the mammalian target of rapamycin pathway in the pancreatic neuroendocrine tumors. Of course, it has been detected that it was wild in a couple of research or data or trials, which was done on pancreatic neuroendocrine tumors, and then it was tested prospectively in the RADIANT-3 in the pancreatic neuroendocrine tumors, and demonstrated again a significant progression-free survival, and also with the extra pancreatic neuroendocrine tumors, again a significant, very significant hazard ratio of 0.39% with the extra pancreatic, and it's the only one that has been tested prospectively there. Again, we have always the option of chemotherapy, and one of the older trials which tested streptozocin and adding 5-FU and DOX to it. Of course, the most common or the highest response rates were seen with the streptozocin doxorubicin, but the more commonly used is the streptozocin with the fluorouracil, again with the data which was recently published a couple of years ago with the CAPTEM, again showing overall response rates which is very competitive of around 40% in the metastatic cases. What's the optimal sequencing of the lines, of the different lines of treatment that we discuss right now? This is the question that's being tested right now for the neuroendocrine tumors. There is a phase 2 trial, the ocular random, and actually there is a phase 3 now that's being also under publication. The phase 2 trial of the ocular random, which randomized the treatment using lutetium versus sunitinib in pancreatic neuroendocrine tumors, again showing a significant improvement when using the lutetium dotatate. Sorry. The second trial, which helped to answer the question of the sequencing, is the sector trial, which is a phase 3 trial. We're waiting for the data, only we're having preliminary data. Now with the progression-free survival, again, how to give or what to give in pancreatic neuroendocrine tumors. So to give everolimus, then chemotherapy, or chemotherapy, then everolimus. It demonstrated a slight improvement when starting with the chemotherapy before the everolimus, the arm B, which was significantly better than the other option, or starting with everolimus and then switching to chemotherapy. A lot of trials now are ongoing to determine the optimal sequencing. And in the guidelines, of course, one of the nicest, the European Society guidelines, which tackled pancreatic neuroendocrine tumors and what to use with, targeting them with the grade 1, the grade 2, and the grade 3, usually using or residing to using somatostatin analogs, the long-acting ones, of course, as a first option. And then whenever there is a progression, we might use the other options, either the chemotherapy, the TKIs, or the mTOR inhibitors, with the use of lutetium being far away or in the third line. And the problem with that is the quality of the evidence of the lutetium. It's not that solid, and the data is not mature yet. Again, with the neuroendocrine tumors of grade 2, we usually reside not to the somatostatin analogs, but basically to the chemotherapy, everolimus, and sunitinib. Then our second option is the lutetium. In the grade 3 and the SSRT negative, we usually reside to more aggressive or a bit more aggressive therapy. Again, for the lung carcinoids, the only drug that has data is the everolimus, the mTOR inhibitor, to be followed by the TIM-based chemotherapy. Then, if progressed, we might use the lutetium, interferon, or platinum-based chemotherapy. So our take-home message, neuroendocrine tumors are heterogeneous, and the prognosis varies, of course, according to the behavior. Well-differentiated often express the somatostatin receptors. Using the cold somatostatin analogs is very useful in control of the hormonal syndrome. Systemic therapy using in the pancreatic neuroendocrine tumors, using the nereotide, sunitinib, everolimus, chemotherapy, lutetium, and sorafenib. GI, usually the same way. The lungs, the everolimus and sorafenib. Optimal sequencing is still under the cooking, and the predictive markers and precision medicine are major pending issues. Thank you all, and I'm happy to take any questions.
Thank you, Professor Mohammed Shazly, for your elegant presentation. Dr. Amr Abul Majd. Okay, we open now the session for discussion. Any question? Dr. Mohammed Shazly. Thank you so much, and we shift to the second session.